Good morning, everyone. Thank you for joining this new tech lecture. Today, I want to talk about acne scar, but not just the surface, the architecture below the skin. My title is Beyond Conventional Needle RF for Acne Scar. I'm Shinhae Park, an aesthetic physician. I am the director of Miho Clinic in Busan, Korea. I also work as a KOL and clinical educator for several aesthetic medicine. My focus is on energy-based device, injectable acne scar, and combination procedure. Let's start with one simple idea. Acne scars are not just surface mark. They are three-dimensional structural problems. Look at these three types. First, rolling scar, a broad depression with tethering deep in the dermis. Second, boxcar scars, sharp edges, a flat floor. Third, ice pick scar, a narrow opening but a deep track going down. Each of these are a different shape, a different depth, and different problem. Now, here is a problem we see every day. Look at the top, same setting on every patient. 1.5 millimeter depth, 9 watts, same pulse. But look what happens in 4 different areas. In a thin temple, the needle goes too deep. Past the dermis, the risk is too deep. In a thick cheek, the same depth sits in the mid-dermis. We may undertreat. On a rolling scar, the surface goes up and down. Needles enter unevenly. On a boxcar scar, same problem. The walls are not flat. Engagement is uneven. So the screen of the machine says the same number, but the actual biological dose is not the same. The display depth is not equal to tissue engagement and not equal to thermal effect. So if depth alone is not enough, what is the solution? Let's think about why needle RF makes sense as a platform. Step 1, mechanical entry. The microneedles go through the epidermis. Small entry points, minimum surface damage. Step 2, intradermal RF. The RF energy creates dermal zone inside the dermis, where we want them, not the surface. Step 3, fractional remodeling. Over time, the dermis may reveal collagen, with the surface mostly preserved. This is important for Asian skin. I want to introduce a simple framework called ELADAM, 4-dimensional control. This is how I think about ELADAM. First, tissue engagement, vacuum assist to capture the tissue. Second, spatial control, depth and frequency to locate the energy. 3, temporal control, pulse or continuous, to shape the pulse. 4th, epidermal tolerance, DCD cooling to protect the surface. 4 short verbs, engage, locate, shape, and protect. First dimension, tissue engagement. Let me show you the problem first. On the left, no vacuum. The scar surface is irregular. The tissue moves. We see tenting under the tip. The needle enters at different depths. So even with the perfect centering, the actual engagement is uneven. Now look at the right with vacuum assist. The tissue is pulled into the cartilage, held in a stable dome. All needles enter at a more uniform depth. Second dimension, spatial control. Depth is one part, but there is another, frequency. Frequency shape where the heat goes around the needle. Let me show 3 patterns. 1 megahertz, a broader thermal field. The heat spread out more. 2 megahertz, a more focused effect, right next to the electrode. And dual sync, both in sequence, a mixed pattern. Third dimension, temporal control, how energy is delivered over time. 2 mode, pulse, and continuous. On the pulse mode, the RF comes in segment with off time in between. Look at the temperature curve below. The heat builds up gradually, step by step. On the right, continuous mode, one interrupted bar, the energy goes in without a break. The temperature curve rises and stays high. Sustained thermal deposition. So here's my point. Pulse mode is not simply weaker than continuous. It is like different type of energy delivery. Fourth and final dimension, epidermal tolerance. This matters a lot for Asian skin, especially because of PIH risk. On the left, without cooling, RF heats the dermis, but heat also accumulates on the surface. See that red band near the top? This is the superficial thermal burden we want to reduce. On the right, with DCD cooling, the cryogen drops cool the surface before and during the RF. The dermal RF zone are maintained, but the surface stays cooler. So we now have 4 dimensions of control, but that does not mean Eladon fits every scar and Eladon is magnificently do everything for the scar. Let me be clinically honest. Look at this 6-cell matrix. Top row says good fit. My rolling scar, good fit. For broad dermal remodeling. Shallow boxcar scar, good fit. For floor and edge remodeling. Enlarged pore and early atrophy, good fit. For superficial to mild dermal targeting. But bottom row needs combination. Deep tethered rolling scar combination, subcision, plus or minus RF. Deep boxcar scar combination, maybe with collagen stimulators, subcision, punch, or RF together. And the last one, ice pick scar. I don't think RF is the perfect thing for the ice pick scar. So Eladon has a role in scar algorithm, but not as monotherapy for every patient. Now let me show you 3 representative cases for my clinic. This is case 1. The patient had enlarged pore with early atrophic scars. Before and after 3 sessions at 4 weeks interval, you can see pores look tighter and skin texture is more even. The energy logic, 1.5 millimeter depth, 1 megahertz, mid-dermal targeting with DCD cooling. I chose continuous mode here because I wanted sustained thermal effect for diffuse pore tightening. This is case 2, a different kind of patient. She had active inflammatory acne with atrophic scar. So 2 problems at the same time, active lesion and the structural damage from earlier acne. Before and after 3 sessions, 4-week interval, you can see the active lesions are calmed and skin tone is more even. The atrophic depth is reduced. The energy logic here was different from case 1. I used 1.3 millimeter and dual sync, so 1 megahertz and 2 megahertz together. This targets superficial and mid-dermis at the same time with DCD cooling. For mode, I chose pulse mode for her because the tissue was already inflamed. Pulse gives us a gentler accumulation of energy and more tolerable for inflammatory skin. And the last case, this one is different and clinically really important. This patient came to me in my clinic with PIH. She had received needle RF treatment elsewhere, another needle RF treatment, and developed diffuse PIH afterwards. So my goal was here, it was not to push energy, it was like retreat carefully with epidermal sparing intent. Before and after 3 sessions, 4 weeks interval, the pigmentation was clearly improved. skin tone was even. So the energy logic was conservative, 1.0 millimeter and only 2 megahertz superficial focused plus DCD cooling to reduce superficial thermal burden. And pulse mode, because the tissue was already damaged, gradual accumulation was needed. Epidermal sparing intent matters mostly in PIH, Crohn's skin, like us, Asian. So let me close with 3 messages. Number 1, acne scar is a 3-dimensional structural problem, not a surface problem. Number 2, Eladom, the edge control across 4 dimensions, tissue engagement, spatial geometry, pulse timing, and epidermal tolerance. Number 3, the goal is not more aggressive injury. The goal is better matches dermal remodeling at an acceptable epidermal cost. This is my references, and thank you for your attention. I welcome your question and your discussion. Thank you.
Yes, Dr. Torre. Oh, sorry, we didn't see the chairman or moderator. He's not here. Okay,
Hello everyone. Well, firstly, thank you for being here. So what we have to present here is a product we have started to develop, and we are starting in the market very, very recently, which is called Managen. So the company Fakhron Genomics, we are specialized in genetic testing. So we have been developing genetic testing to improve how patients are treated. So essentially how we personalize treatment of patients. And now it was a time to start with women's health. So what we've done now with the Managen is that we have found ways to improve and ways to make hormone replacement therapy safer for patients. So I always ask the questions as to whether does genetic improve or does genetic alter the therapeutic outcome of patients? And I think this is an important question to anything that we launch new into the market, is to, does it actually improve how patients are treated? Does it actually improve what patients are delivered? Otherwise, it doesn't make sense. And we have seen genetics play a very important role, both economically and also therapeutically in many areas. And we are now sure, after our statistical work, that we also are able to do so for women's health and for menopausal or perimenopausal women. And then we want to go finally to actually menopause. Just before we start with the product itself, there are some important aspects here I always like to stress when we're talking about menopause. First one of them is that menopause is not a random presentation. So it's not something a woman decided and invented. It is a pathological, it is a disease known, it is a known process that is listed under the ICD-11 here, GA30. And it couples very well, obviously, with women aging. So what we see in the surface is the diagnostic, but obviously there's a range of molecular alterations happening in the background. So below the clinical summary or below the clinical horizon, there are loads and loads of processes happening below. So there are loads of processes that lead to menopause happening. And an important aspect of menopause is obviously the clear hormonal alteration. So although obviously we see hormonal alterations happening in menopause, there are other aspects that help us understanding the risks associated to hormone replacement therapy, but also to how are these women feeling in reality. And one of those is really how women are under stress because they are aging, and also they are presenting the menopausal state. And what do I mean by that? One of the main factors that lead to alterations in how hormones play and how how humans and how women behave during the perimenopause and menopausal state, is that we see that although, or apart from the fact that women are developing menopause or are under the course of menopause, we also are increasing in obesity. So as women age, obesity, weight gain also happens. So obviously there are other metabolic alterations happening at the same time. And doing HRT is not simply giving women hormones, we are helping them to pass through this time of metabolic stress and metabolic alteration. So we have to take into consideration, obviously, all the metabolic alterations that happen during menopause, not simply because they only have hormonal alterations, but because we have seen in our research several dots being connected, and this was how our statistics has shown it, that we have inflammation, we have aging, we have weight gain, all of them happening at the same time, and all of them with some biological process and some molecular process happening in the background. So we do have a shared genetic pathway that goes along hormone synthesis, weight gain, inflammation, and so on, and obviously the metabolism of many of the vitamins and minerals that are linked to the production of hormones. And obviously on the other side, and likely very important in terms of how we decide how to treat women, also obviously the steroid hormone synthesis. So to summarize a bit what happens in menopause and how does it touch genetics, we have obviously a decline in estrogen production, and we have several markers, including the aromatase and the transport enzyme, that when they are altered, they also alter the perimenopausal state and menopausal state in women. We have inflammatory and oxidative stress pathways that also do influence in the estrogen metabolism and how women will feel about that. We have the dyslipidemia control, so this goes back to the fact that women are also going under a stress related to obesity and to metabolic alteration. And finally, when we have menopause, these fluctuations in hormones, they are going to amplify these other mechanisms. So this is the aim of Menogen, is to see these alterations so that we can predict how these patients are going to be better treated. And this takes us now to the second and last part of the basis of the product, which is the fact that also alterations in the metabolic pathway. So if patients are metabolizing more towards the steroid axis through the aromatase enzyme or towards the adrenal side of the metabolism, all of this is going to lead patients to being more or less prone to being or to succeeding or to needing a certain hormone during hormone replacement therapy. And finally, during this initial basic part, because this is more important, we have the fact that hormone replacement therapy does pose some risks, and some women have more or less risks related to thrombophilia and to cell proliferation. And this takes us finally to Menogen. So what is Menogen? Menogen is our product that will allow us to use this genetic information, interpret it, give it in view of clinical risks, and finally allow us personalizing HRT protocols in patients. So what we do in the practice is that what you do is that you swab your patient in a clinic. So you just swab patient in a clinic, send it to a laboratory, and you have access to a report containing what you need and how you can treat your patients better and safer. This is what you will view in the report, like very on a high level. What you view in the report is going to be the genetic variant. So the genetic variant we have found statistically to be relevant in this matter, and they are divided in 9 biological categories related to how we treat patients, how we can decide on which hormones, and how these genetic categories decide the hormones to be used in the hormone replacement therapy, and also formulations that can be used to mix the hormones and make it more practical. We all are used to compounding pharmacies and to compounding medications to hormone replacement therapy. So the categories we have on Menogen are essentially 9 biological domains that we have linked statistically and biologically together to the 34 variants we study. So this is essentially going to be estrogen synthesis, estrogen metabolism, estrogen transport, so namely basically the transport protein, cardiovascular risks, bone risks, brain risks, and the deficiencies of folate and choline, which are very much linked to the production of steroidal hormones. And last but not least, you see the formulations. And this is just a statistical view of how relevant these genes are in deciding how biology plays a role in HRT. What you see here is a logarithmic scale that goes like above here, and we go up until a p value of minus 300. So these variants, they are very well linked to how women are going to respond to HRT and how we can biologically predict how good this is going to be. For us to finalize, so the final aim of the Menogen is to deliver safer and more precise therapy. So we have some key genes which you all know to be relevant in the production of hormones, but now with Menogen, we know they do play a role in deciding how hormones can be replaced in these women and how well we can do this and how safer as well we can integrate this. So again, what we do is that we have genetic information, we have them linked statistically to the biological categories, to the biological domains related to HRT, and finally we deliver it to you in the format of a formulation. So we have hormones and formulations you can use directly to provide a better therapy for your patients. I would like to thank all of you. I have an overlapping talk, so my colleague will be here if I can't stay for the questions because I have an overlapping talk at the level 4. But also I'll be with them in the booth right in the first aisle. So if you need any information from us, we are Fachron Genomics, and we are the ones delivering our Menogen and our genetic solutions to personalized therapy. Thank you very much.
Good morning, everyone. Today, I would like to share about actually, it's not the new technology, but it is ultrasound. But usually nowadays, ultrasound we use in aesthetic to help to identify the filler complication or any injectable. So let's start. This is the textbook of ultrasound that I think if someone wants to learn more about the ultrasound, this two of this is very good. So the role of ultrasound is, the first one is to prevent complications, identify cosmetic filler, diagnose complication, and also we can use ultrasound guide injections as well. For the first one, if you want to prevent the complication, we can use ultrasound to do the vascular mapping, especially in the high risk area. For example, if you want to inject at the temple area, as you know that the temple area is very high risk area, or even on the forehead. Nowadays, it have many machines of the ultrasound, the big one and the portable one. And the portable one now it just have some brand have just on the finger, so it make you easy to use. You ultrasound and you can inject both together. The next one is I think everyone can use ultrasound to identify cosmetic filler. For example, you inject the HA filler what do you think that the HA will the characteristic of HA, what do you think, is the black or white? Do you have any idea? White or black? Black. It should be black because the HA is composed mostly at the water. So the water, it should be black. So what is the black in the undersoil? It have many black, right? So you have to think that the HA, if it's just only the real HA, no complication at all, it's just homogeneous hypoechoic one, so real black, homogeneous. If you see, you're not sure that this is black or gray or have a little bit white, be careful. Maybe it granuloma or it has complication for the infections. I have a case to show you. This lady, she inject two of injectable things. The first one is HA. The second one is PLLA. So after 1 month, she have history of lumpiness on the temple and on the under eye. But she didn't know that where it should be. So you can use ultrasound to guide to identify which material. For example, at the right infra orbital, I see the HA. You will see that it well defined, and the HA may be hypoechoic on an echoic, just black and homogeneous one. This one is, you can identify that this is the HA. And for the right temple, she inject, you will see that this one is not real black. It have a little bit white. I know that may sometimes it's difficult to identify, but if you learn your eye with the ultrasound, you can identify that this one may be PLLA because it have a multiple hyperechoic granular dot with. If it's PLLA, it will have posterior acoustic shadow. Where is it? Let's see. You will see that ปิดไฟด้านหน้าได้ไหมคะขอบคุณค่ะ Okay. You will see this, the black, and it have a white, and you see in my pointer, this is called posterior acoustic shadow. So this one is confirmed that it should be PLLA more than HA, because if it HA, it's just only black, homogeneous, and no posterior acoustic shadow. The next case, she have a history of the neck lumpiness on her neck after she inject Carha injection. I will not mention the brand, okay? But it's Carha. She confirmed that she inject Carha. And what you will see, because it turned maybe more than 4 months, and she already tried to inject by normal saline injection to dissolve it, but it not improve. It didn't improve at all. So what you see, you will see that this is a lumpiness on her neck, and this is the lump on her neck. You will see, what should it be if it is color? Black or white? White for sure, right? Because it's a bone. This one, you will see that the white one. And I would like to emphasize that it not will the white all of the lump. It will just the particle of the color. So that is why you will see the white one like this. So for this case, I inject via ultrasound guiding to treat normal saline injection on the lumpiness area. So if it calcium hydroxyapatite or color, for sure it will white, and it will have posterior acoustic shadow. I would like you to imagine the ultrasound is like the wave. If you ultrasound something and, for example, it is like the calcium, the wave cannot penetrate after the calcium. So that is why it can cause the posterior acoustic shadow. But if it's like PCL, you have to imagine that which type of the PCL, liquid or gel form. Usually the gel form of the PCL, you will see that multiple heterogeneous hypoechoic one. And you will see like the posterior acoustic shadow, but it have a form of mini comet tail artifact. The next is, this is very common in Thailand, that someone inject unknown things more than 10 years ago on the nose. Could you guess what it is? No idea? Filler? Silicone? Let's see. Okay, she inject unknown things 10 years ago, and she came to me that she have the tender lump on her nose. So I ultrasound first. You will see that this is the characteristic of the silicone. It calls snowstorm pattern. You will see that if you see this, you can diagnose it, definite diagnosis. This is silicone because it have a characteristic one that it will define homogeneous hyperechoic deposit, like the snowstorm artifact. Like this. This one is the characteristic of the silicone. The next, this lady, she have the palpable at forehead. After injection, both things. The first one is HA. The second one is autologous fat gap at Korea. She didn't know that what it is. It's from HA or autologous fat. So let's see, ultrasound. What do you think if it fat? It should be or HA that you know that this one is like this. And the next area, this one. Homogeneous. Yes, this one is HA for sure. All black, right? So you can identify this is an HA. So this one is the HA. No fat. If it's autologous fat gap, you will see in the ultrasound that the ultrasound will show like the well-defined hypoechoic one. And maybe from time to time, it may be have more echogenic, and sometimes it will have fibrosis and cystic chain. This is the characteristic of the fat. If someone come to you that she have tender lump on her face after injection something, what should it be if it's infection, for example, abscess or granuloma? You have to identify, you have to imagine that because of infection, even though it have granuloma or abscess, it's not just like the water like HA. Maybe it have a water, it have a pus, it have a blood, include all. So that is why if you see in the ultrasound, you will see like the mixed one, both black and white. You will see that it have a mixed hyperechoic mass. And if you do the vascular mode, for example, Doppler, you will see that it have peripheral vascularization. This is confirmed and tentative that this is the abscess. For example, this is from the paper. You will see that this one. You can identify, differentiate from the HA because it's not real black, right? It have a black and white, and when you see it have a peripheral vascularization. This is my case. She have a tender mass at neck area after injection the HA. You will see from the ultrasound that this is the size or the shape is not round. It's not round, it's not oval, or it's not circle. You will see that this is almost black and white. And after I do the Doppler ultrasound, I saw that it have a peripheral vascularizations. This one. So for this case, you can treat by empirical antibiotic. For example, for me, I will prescribe the oral augmentin combined with clindamycin and follow up her again. If it's still not improved, you have to do the skin biopsy to check the pathology to see the granuloma or not and to identify the material, and also you have to send all of the culture, bacterial, fungus, and mycobacterium. The next one is if you have the case that have the vascular obstruction, what will you see in the ultrasound? I think when the vessel is like the tree, the main tree, right? The tree, if it have an obstruction, for sure, the proximal, the vessel that have an obstruction will dilate, okay? And collateral vessel will try to increase more vascularization to help to maintain blood flow. Okay, this is my case. Could you do not take a photo? She inject the HA injection 3 days ago by the unlicensed practitioner. You will see that which brand that you think maybe she have the skin necrosis at the maybe supraorbital, right? You will see that sometimes you will see not real obstruction because this case it turned to 3 days after that she didn't have the ocular symptom at all, so just skin necrosis. So for the clinical, for sure it's not real 100% obstruction. Maybe it's just compression. You will see on the ultrasound that this is the bone, the the orbital bone, and this is the notch. The white line is the bone. The white line is the bone. So you will see the skipping area. This is the knot, supraorbital knot. And you will see this one. This is like the HA material. It compressed up the supraorbital. So that is why she has skin necrosis. I also check the superficial temporal vessel and deep temporal vessel. It's okay. This is a treatment offer. After treatment, I confirm again by did the ultrasound and do the Doppler flow. This is the normal flow of the artery. Another case, 2 days ago, she have skin necrosis. Again, for this case, you will see that this is like the filler material and it compressed at the bifurcation of the temporal vessels. After treatment, the flow is getting better. This case, she developed the skin necrosis after HA injection at Korea on her nose 6 days ago. I did the ultrasound. So for this case, what do you think, what is the arterial branch that hit for her? What do you think? Which branch of the facial artery? Maybe lateral nasal or columellar? Okay. I do the ultrasound. You will see that if the flow is okay, you will see the flow all around the tract. But you have to imagine that because of our vessel, it's not the straight thing, it's 3D. So when you do the ultrasound, it's just 2D. So sometimes you see that it have some disappear. Because it's 2D, it's tortuous vessel, right? You have to see the flow. So the flow of this case is still okay. After treatment, I treat her by LED hyperbaric oxygen and oral aspirin and prescribe her an oral antibiotic. 1 week later, she better. The last one is this lady, she have a facial mark edema after injection the HA. For this case, at the first time I did the ultrasound, I see that yes, it is the HA, But the prominent thing of this case is she have the loculated of the HA on her cheek. So for this case, I did the skin biopsy and check the culture, all is negative, and the biopsy show that it confirmed that this is the HA. So I use the ultrasound to guide and inject hyaluronidase for her. Last but not least, I would like to conclusion that nowadays ultrasound is like the real-time visualization to treatment. You can use this one for prevent the complication, and if it have the complication occur, you can use the ultrasound like the guide for your treatment. Thank you.
So good morning, everyone. I'm Dr. Megha from India, consultant dermatologist and founder of Dermalexer. So today I'm here to talk about the topic CO2 laser, how it has changed from ablative and resurfacing device into a regenerated platform for me. So it targets the different modalities if we combine the treatments for the structural support, for regeneration. If we combine the other chemical and energy-based modalities, over the next 10 minutes, I'll be sharing my practical combinations, strategies that I use in real-world clinical cases. So traditionally, we all have used CO2 as an ablative device to remove xanthelasma, warts, moles. So we have used them. But modern fractional technology has changed this by creating a controlled microthermal injury and while preserving the surrounding tissue. Fractional CO2 stimulates the wound healing, collagen remolding, and regeneration. This evolution allows us to move beyond tissue ablation or resurfacing towards restoration. So why monotherapy has limitation? It's because most of the aesthetic concerns are multifactorial. So for example, acne scars, there is textural irregularity, dermal tethering, volume loss, and pigmentation and inflammation. So rarely a single modality can address all the concern. So treatment success mostly depends on identifying the pathological layer and then matching it with the most appropriate modality. So the combination strategy which I usually use is divided into 4 domains. First, the structural, where I use subcision, threads, and fillers to restore the architecture. Then the regenerative PRP, PRF, PDRNs, and even exosomes to enhance the healing. Then the chemical TCA cross and some peels to correct the scar component. And then combining it with other energy-based devices like CO2, Q-switch Nd:YAG, MNRF to initiate remolding. So the objective is not just adding treatment randomly, but selecting complementary mechanism targeting the pathological layer. So these are the cases. This is a case where I was rolling scars. So it responded very well to subcision, which was followed by fractional CO2 and PRF to have enhanced healing. So this is another case where I did a CO2 resurfacing with the regenerative microneedling and PRP. This is with the 7 sessions, 3 to 4 weeks apart. And the aim was not just increasing the energies, it was smartly combining the therapies to attain a maximum result. So this is a patient that he has deep ice pick scars. So where I performed TCA cross, and then there was regenerative support given along with CO2 resurfacing. And patient was very happy. This is with the 9 sittings. 4 weeks apart. So in this case, there was some volume deficient. So this required some monothread support for the structural support along with PRP to enhance the healing and CO2 resurfacing. So in each scenario, structural release is combined with biological stimulation and surface remodeling, producing a superior outcome compared with the monotherapy. We cannot expect such results with single modality. So combining all together enhances the outcome. So in this patient, I did exosome-assisted microneedling, and then there was fractional CO2 was done. So as you can see, the atrophic scars has improved in this case. And so the exosome-assisted microneedling and monothread combination represents the next generation of scar therapy. As you can see in this patient, there are atrophic scars where the structural support was given with monothreads. Then it was combined with CO2 lasers. The monothreads were given in 3 sittings, 20-20, almost 20 on per side in a crisscross pattern along with CO2. So results were quite amazing. He did CO2 7 sessions, but monothreads was used twice. So these approaches amplify the cellular signaling, collagen production, and tissue repair, while CO2 provides a regenerative trigger. The result is better integration of texture improvement and dermal remodeling. So this is a complex post-traumatic scar. So this patient underwent some plastic surgery. After that, he ended up getting this. It was a very small scar. He did a plastic surgery, and this was after that. So in this case, it's a complex case where there is contour deformity, texture irregularity, and pigmentary changes. So in this case, I did fractional CO2 to refine the margins to merge it with the surrounding skin, and the cereals of PRP was given to enhance the healing. Then the soft tissue augmentation was done for the defect that he had, and this followed by low fluence Q switch Nd:YAG lasers was given. So it was a whole journey of like almost 12 months which patient did with me, but he was very happy with his results. The soft tissue augmentation I did at last. Initially I was trying to enhance his healing. So as you can see, each modality addressed a different component, ultimately improving the contour, texture, and color blending. So keloid, as we all know, requires a balanced approach. Fractional CO2 can soften the texture and improve integration with the surrounding skin, while the main anti-fibrotic approach, that is the intralesional steroid, remains the standby treatment. To control the excessive fibroblast activity, intralesional steroids were given, and staged treatment was planned to minimize the reoccurrence rate. So this is a patient of post-acne pigmentation with some textural changes. So combining fractional CO2 with low fluence Q switch Nd:YAG gave her a very good result. Simultaneously, it improves the texture and pigment while reducing the need for aggressive energy escalation. So this is the result with 5 sittings. So first the Q switch Nd:YAG was done, then a low level of resurfacing was done with CO2 laser. So this is a patient where fractional CO2 was combined with regenerative skin boosters to enhance the collagen remolding and skin quality and overall rejuvenation. So rather than just replacing energy-based treatment, regenerative injections optimize the healing response generated by the laser, and she was quite happy with it. So these were the 2 sittings a month apart. 2 ml of skin boosters were injected in this sitting, and fractional CO2 was done for resurfacing. So this patient is a case of acne excori. So in this, the sequence of salicylic acid peels were done with the low level of CO2 was done. So the timing and patient selection is very critical to optimize your result. For you have to prevent the excessive irritation also. So first the session of peel was given and then the resurfacing was planned. So now let's talk about the laser-induced dyspigmentation. I think every one of you must have experienced it in your practice. In Asian skin especially, it's very prone to hyperpigmentation. So post-inflammatory, hyper and even the hypopigmentation. So prevention remains very important. So it is always better to prevent rather than to correct. So excessive fluence, inadequate treatment intervals, increasing the energy randomly. So this should be avoided. Because excessive fluence, inadequate intervals, aggressive treatment, these all increases the chances of complication. So conservative staged correction, barrier repair, complete strict photo protection and gradual remolding should guide decision making. So goal is not maximal energy delivery but controlled biological response. So I'll show you some cases. So this is a patient of nevus of Ota. She came to me with this molted hypopigmentation. She did 5 sittings of Nd:YAG laser somewhere else and then she ended up getting this molted hypopigmentation and she was very worried for it. So here I planned the treatment. I did fractional CO2 over the hypopigmented lesion and 2 sittings of PRP was also given to improve the texture quality. And then I planned a low fluence Nd:YAG laser which also faded her nevus and plus blended her that hypopigmentation. So patient counseling is also very important in this. This is another case of nevus of Ota. She also did laser Q-switch Nd:YAG 9 sittings she did somewhere else and ended up getting this hypopigmentation. So patient was very unhappy, very dissatisfied. Then I planned her treatment. I did first CO2 resurfacing for the hypopigmentation and some sessions of PRP was also given to enhance the skin quality. And then I planned a low fluence Q-switch Nd:YAG where the improvement was very nice and patient was very happy. So this is another case. She did laser toning for skin glow and melasma. So we all are scared of using lasers in melasma, but she did it somewhere else. She did 3 sittings. So after that, she ended up getting this hyperpigmentation over the skin. So there I did CO2 resurfacing along with some glycolic acid peels and strict sun protection and oral tranexamic acid. And the result was very well blended and patient was quite happy. So the take-home message is fractional CO2 is not just an ablative device or resurfacing device. It's more now a regenerative platform. So combination therapy should be indication specific. Structural support, regenerative correction and improves the outcome. So structural correction, biological stimulation and surface remolding together produce a most meaningful outcome. The future of resurfacing lies in intelligent combination rather than high energy delivery. So thank you for your attention. I'm looking forward for discussing your experiences and answering your questions if any. Thank you.
Is this your pointer? Do you need this pepper?
Good morning. I'm Dr. Sang-Soo from South Korea. Today I'm going to talk about the microwave and the long pulse Nd:YAG laser, which produces a fractional laser beam. And these two devices make, when you use this combination, you could target dermis and also the subcutaneous area. So when we think of the aging, there's a lot of problem with the laxity, tightness, and pigmentation and wrinkles. So as previous lecture, she made a lot of good combination treatments. The combination treatment is very needed with devices, skin boosters, and thread, and also cosmetics. And today, I'm going to talk about the combination of making treatment with the devices. The common devices that we use with HIFU and radio frequency and lasers. And before the microwave devices have been introduced, the HIFU was the only device that could target very deep subcutaneous area, like also to smart area. But the problem is that the HIFU makes a very high temperature, more than 60 Celsius. So if you go over 70 Celsius, then you could make a nerve injury. That's why the microwave device is more effective and more safer to use to target the deeper area. These are the devices that I use. I also use a monopolar radio frequency, HIFU, bipolar radio frequency, microwave, and acoustic wave devices. And I'm going to talk about this microwave device today. And also I use lasers like QC-HNDR, picosecond, and long pulse, and CO2 fractional of MEAG. And this is the other lasers that I'm going to talk about today. So about the microwave, it makes an electromagnetic field, which causes a dipolar rotation of the water molecules within tissue, so it makes heat in the subcutaneous area. The main target will be the subcutaneous area, which you see in the picture that 80% is the target, and also it targets the dermis area. When you compare with the radio frequency and the laser, the microwave is much more deeper, and radio frequency mostly target on the dermis area. If you use an ablative laser, you can target superficial area, especially on the epidermis. And the ablative laser is very effective for the skin texture improvement. The 2.45 gigahertz is the frequency that you use for the microwave. And this causes a higher loss tangent, which makes it efficiently convert electromagnetic energy into heat. And you can see from this video, is it coming? When we rub this device into the peak, this is a peak, and the thermometer is, the middle one is placed on the dermis part, and the other two is placed on the subcutaneous area. And after rubbing this, the left picture is the before, and the right picture is the after about 5 to 10 minutes. You can see that most of the heat is formed on the deeper part of the subcutaneous area. So from the article, you can find that the lipid droplets is extruded from the adipose site, and within a month, the macrophage is covered and destroy these lipid particles, and after 2 months, it becomes normal. So I recommend using this microwave device 2 months interval. And about the effect to the dermis, well, this is like a microwave frequency. It doesn't hit the derma directly. It targets the dermal white adipose tissue layer. Dermal adipose tissue layer is between the reticular dermis and the subcutaneous fat area. And this area is very important for the skin regeneration, immune defense, and thermoregulation, and hair cycling. So the precursor cells can become either fibroblasts or adipocytes. So it's very important for making younger skin. And most of the microwave devices produces just continuous pulses. And when you use a continuous pulses in a skin, and rubbing it for like 3 to 4 passes, then the heat will be produced more widely, and that causes the heat to become more deeper. But when we use a pulse mode, very short time and with a high energy, then this will not go much deeper, but we could make a very high peak power in the dermal white adipose tissue layer. So it might help to increase the dermis condition. And also, most of the physicians are very afraid for the effect of the brain. But in my opinion, because microwave doesn't penetrate the skull bone, so it might be very, not very, I mean, it might be safer, but also we don't target on the forehead because there's no any subcutaneous fat area to target over there. We normally target on the jawline and the cheek. So again, first I use a shot mode first, and then I use a rubbing mode to get more deeper of the temperature. And also for the long pulse NDR lasers, there are some articles you could find that it is very helpful for treating the skin laxities, but normally we use a very high fluence with a longer pulse duration, and this causes a very much pain. So there's another article about reducing the fluence and the pulse duration to decrease the pain, but also you have to use lots of sessions to make a better effect. But if you use a fractional handpiece, which is focusing the energy, it can make a very high fluence. But when we think of very high fluence, it might cause like a side effects like burn or very pain. But if you use of this fractional handpiece, the pain is very decreased. So it's very helpful for the patient to be treated. And for the histology view, you can see the collagen has been formed after 1 month. And this is another view. Also, this is another one. And this is the laboratory test that we did. We compared with the 600 microsecond with the 10 millisecond. And because 600 microsecond, this pulse duration may target the arterial in the upper dermis. So you can see from the this step is from 0.5 to 1 millimeters. You could find the fibroblast has been increased in this area. But when we use a 10 millisecond, you could also see there's an increase of the fibroblasts in the deeper area also. And also for the stem cell, only the upper part has been increased in the 600 microsecond. But with the 10 millisecond, we could see the whole dermis area that the stem cells has been increased. So with using a fractional handpiece, although it is very high fluence, there's no any tissue necrosis have been found in the histology view. So it's very safe and effective for the using for the skin tightening treatment. So first, I use a microwave treatment for the first to target the subcutaneous area and the dermal white adipose tissue layer. And then I chose a fractional long pulse NDR laser to target the upper dermis and the lower dermis part. I'm going to show you some cases. You see, I did a 1 session and took a picture after 3 months. And you could see the angle of the trend, and it has been very narrowed. This is another patient done 2 sessions with 3 months interval, and without using any thread, only but using these devices, you can see nasolabial fold has been shallowed. And this also area, you can see this part, the wrinkles, it was very deep, but it became a bit shallow. But if she had used a thread with the also with the device, then the outcome could have been more better. For her also, you can see from the marionette line, it has become a better, but using just 1 session and taking picture after 2 months. This is using a long pulse NDR laser with a fractional handpiece, and you can see the skin texture has become better. Also, for the fine wrinkles underneath the eye, it became better with using just long pulse NDR lasers. With the erythema, and she has like a rosacea, and without using any medication, she had a good treatment, a good outcome. Also, she had like a skin problem with erythema and some kind of dermatitis also became better with combining with the ultrasound. So this is my last presentation. Thank you for listening. If you want to check out the latest trend of Korean medical aesthetics, you could come to Korea in November. Thank you.